Alright, we're going to continue talking about respiratory analysis. So we briefly covered acoustic analysis. I want you to know the three kind of softwares available for that. What are some of the measurements that we obtain as part of acoustic analysis? What's the first instrument to study a spectrogram? All of those basic information. What is required for a good input signal? So the next thing we're going to talk about is respiratory analysis, and we talked about how the three parameters that we're going to talk in respiratory analysis are airflow, volume, and air pressure. Okay, so if you look at this instrument right here, this is just part of it. I didn't bring the whole instrument because it's attached to the computer. So this one gets attached to another piece which has tubes for airflow, two tubes that get fixed to this for airflow, and then there is another tube that gets fixed for pressure, and one of these you see right here, these little tubes that you see here go in and come through this part right here, okay, and it sits out of the tube like this. Alright, hang on, let me close this away. I'll show it to you. So there we go. So, and then there is a tube that attaches to this part of the small tube, and then this tube sits right here inside the mask. So this is called a Rothenberg mask. Okay. Basically, when you ask somebody to measure airflow and pressure, you're asking the person to get a nice tight seal over their nose and mouth with this blue mask. This tube actually sits inside your mouth. It rests on top of your tongue, and the person is going to ask to say P, 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 P as in Peter 5 times. And then the instrument, what it measures is when you say P, your vocal folds are open, your mouth is closed, right? So it's measuring pressure. And then your E, it measures the airflow, because for E, your vocal folds are vibrating and it opens and air passes through that, so it's measuring the airflow. So a pneumotachograph or a Rothenberg mask is used to measure airflow. The normal airflow between your vocal folds that needs to pass, which is measured in milliliters per second, is 100 to 200 milliliters per second. So make sure that you know that information. The normative airflow between the vocal folds is going to be 100 to 200 milliliters per second. Okay. Since we're talking about this, I'm going to go ahead and talk about pressure before we come back to lung volume and capacities. Okay. So air pressure. Now, if you talk about pressure, right? Pressure is something that is built below the subglottic pressure. We talked about a lot of pressures when we talked about the physiology of the respiratory system. We talked about the alveolar pressure, we talked about the subglottal pressure, we talked about intraoral pressure. Now, ideally, in order to understand the respiratory analysis and laryngeal function, I would like my pressure sensing device to be below my glottis. At the subglottal level, I would like a pressure sensing device that will exactly measure my subglottic pressure. But think about the logistics of actually having a pressure sensing tube placed below your glottis. Okay. So this instrument, what it does, it actually measures indirectly the subglottal pressure by measuring the intraoral pressure at the level of the mouth. This tube is actually measuring your intraoral pressure. Now, for example, in the sound P, when we do P, right, the P sound in the P, everything else is closed, right? There is no other pressure, and the pressure that is built at the level of subglottis is the pressure that it should be measured at the level of intraoral. So that's one of the reasons we use that sound as well. So that is an indirect measure of the subglottic pressure. Now, I always like to tell the story, and it's interesting because as part of being a researcher, as part of being a person that likes to understand things, we had a research experiment where my advisor, Kiri Verdellini, was trying to understand how much subglottic pressure is actually, she wanted to measure the subglottic pressure during different phonation tasks. So we wanted to measure at low volume, we want to measure at the normal volume, we want to measure at high volume on 3 different loudness levels. I mean, on a single sound, the ah. Then she wanted to measure at breathy voice, like ah, ah, which is the pressed voice, and a resonant voice, so we had 3 different qualities: pressed, breathy, and regular voice. Then we had 3 different loudness: soft, loud, and normal loudness, and at 2 different pitches. Uh, so all of these tasks, and what they did was, as part of the study, I had to be completely numb. So we had a scope that went in through the nose, a nasoflexoendoscopy. Okay, so nasoflexoendoscopy, meaning a catheter goes through your nose and actually comes out behind your nose and hangs right above the velum, so you can actually get a direct look at your vocal folds. So I had to be numb in my nose. Then I had to be numb in my oral cavity and my vocal folds, because what they did was they had to have a rigid scope that goes in through my mouth to view the vocal folds, and through the flex endoscope that went, a catheter was passed, and there was a small pressure sensing tube, a metal tube that went in through that catheter. And actually, when I was producing the sound, the catheter was slowly advanced forward, so it would go between my vocal folds like this. It's a very thin, very minute tube, and they had to kind of drill a hole in that tube. It's a very thin metal tube, like how you would see in your pencil, right? If I had one, I can show you, right? The lead of your pencil, that's how thin your that sensing tube was. Okay, I can't find it. That's how thin your sensing tube was. And then once you found the sensing tube, they had to drill a small hole, because it needs to take the pressure, it needs to measure airflow and pressure through that sensing tube. So they would pass that tube right in between my vocal folds anytime I phonated, then they would take that out away when I was breathing, because it didn't want to interfere with anything else. It was all fun. I was totally numb. I could feel nothing from my nose through my vocal folds. Actually, it's a scary phenomenon, because you won't know when you're swallowing. I was drooling like crazy. It's all, I know it sounds very gross, but it was a wonderful experience. But when that happened, they also, when they were trying to move that sensor up and down, remember how they drilled that hole? That hole was slightly sharp. I think they actually kind of went through my vocal fold, causing some bleeding on my vocal fold. My voice sounds fine now, but then the doctor that was doing the procedure said, okay, we don't need to proceed now, obviously, because you don't want to injure my vocal folds. But the purpose of me telling this is research studies have been done to measure pressure directly at the level of the subglottis, but you can see how many complications are there to doing that. So we as clinicians do an indirect way of measuring the subglottic pressure by measuring intraoral pressure on the sound P. All right? Other ways to measure air pressure is a manometer. So you actually blow into a tube and it's measured in centimeters of water. So how much can you move the water by will tell you how much air pressure is there. Now, we all know the minimum subglottic pressure required to initiate phonation is 3 to 5 centimeters of water, and to maintain phonation is 5 to 7 centimeters of water, right? Now, the final thing we're going to talk in respiratory analysis is going to be about lung volumes and capacities. If you remember, we talked about a lot of lung volumes. The tidal volume and the vital capacity are important things that we measure that is important for speech. Okay, of all the volumes that we talk, of all the capacities we talk, the tidal volume and vital capacity are 2 important parameters that we would like to understand as part of respiratory analysis. Some of the instruments available to do that are a spirometer. If you can look at that, there's a tube that goes in, and if you look at this drum, there's water inside this, and this drum has to elevate up, and there is a reading of how much pressure, how much volume that you could move that drum to. Okay, so that's the volume using spirometer, and that's a full body plethysmograph. It's scary, right? Claustrophobic. Yes, it's a full body plethysmograph. Basically, it measures your lung and thoracic abdominal volume movements inside that, and will tell you how much vital capacity and lung volume you have. But one thing that I want you to observe is that in both of these, if you look at the mouth, right, see how it affects normal speech production, right? You really can't produce much speech with that, okay? So it's important to understand maybe at rest and how much is available at rest in order to use it for speech purposes, okay? So respiratory analysis helps us understand how much air pressure is required, how much airflow is there after we have the pressure, and how much volume is available for us, the tidal volume and the vital capacity. An instrument to measure airflow and pressure. Now we use an indirect way of measuring the subglottic pressure through intraoral pressure. It's the pneumotachograph, the Rothenberg mask, right? And then you have the lung volumes, which can be measured through a spirometer and a full body plethysmograph. I want you to know the names. I want you to know the norms. The norms for airflow is measured in milliliters per second. It's 100 to 200 milliliters per second. For subglottal pressure, the pressure sensing devices could be subglottal or intraoral. And I'd like you to know that the pressure sensing device, the normal subglottic pressure, or the minimal subglottic pressure to initiate phonation is going to be 3 to 5 centimeters of water, and the minimal subglottic pressure to maintain phonation is going to be 5 to 7 centimeters of water. Okay? And that's an example of how the system goes on in your nose and your mouth. That sums up our respiratory analysis. I have a link to K-Metrics which talks more about this product. So if you want to know more details about this product, just click on that link. It should take you to the page. It's called the Phonatory Aerodynamic System, PAS. Phonatory Aerodynamic System, the PAS. It's an instrument that helps us obtain measures of airflow and pressure. It gives us an indirect measure of subglottic pressure. So if I asked you, give me an instrument that helps us measure airflow and subglottic pressure, you can talk about the instrument, which is the phonatory aerodynamic system. You can give an example as a Rothenberg's mask. You can give me manometer for pressure, right? So be careful when I ask you the question whether I'm talking about pressure, whether I'm talking about airflow, whether I'm talking about volume. Each of the instruments do different tasks. So I want you to be very careful when you give me an answer of what the instruments are to measure respiratory measures. All right? Okay. Now we're going to talk about the laryngeal function. I briefly talked about endoscopy, right? Rigid and flexible. And then there's something called stroboscopy. So endoscopy is basically just a scope that goes in your mouth, or a flexible scope that goes through your nose. It helps us visualize the vocal folds, right? Vocal folds are the pearly white structures which vibrate to produce the voice. So it helps us visualize the vocal folds. Now, if I just use an endoscope with a halogen light, you all know what a halogen light means. Remember how many times our vocal folds vibrate in a second? For females, it's about 200 times a second. For males, it's about 100 times a second, right? Now, can our naked eye, do you think our naked eye will be able to visualize the vocal fold movement? The answer is no. If I did just a regular endoscopy, whether it's rigid or flexible, whether I go in through the mouth or through the nose, if I just did an endoscopy, all I'm going to see is a visual blur of the movement of the vocal folds. Yes, I can visualize the vocal fold when they're at rest. I can also see like a blurry movement when they're moving, but I really can't see the vibratory characteristics of the vocal folds. I can see if there's a lump bump, any gross lump bump on the vocal fold. I can see if there's gross paralysis of the vocal fold, right? Because one vocal fold will not be moving, but I won't be able to see how the mucosa looks like, what's the kind of closure there is between the vocal folds, what is the symmetry between the vocal folds. All those are things that I would require something more than a halogen light. That's when people came up with something called a stroboscopic light. It's called a video stroboscopic examination of the vocal fold. The video stroboscopy can be rigid or flexible. Rigid meaning it's a rigid tube of this length, but only a certain point, this small size, goes into the mouth to the back of your uvula, and then you tilt down about 45 degrees to get a view of your vocal folds. Flexible is a catheter that goes through your nose, and you get a look at your vocal folds from above. Stroboscopy, what it does is it actually gives you an optical illusion, meaning what it does is it captures different time points from different vibratory cycles and makes it give you an illusion that you're actually seeing one cycle of vibration of the vocal folds. Okay, so when you look with the video stroboscopic evaluation, you see as you're seeing one cycle of vibration. Obviously, you're not seeing one cycle of vibration, but you're actually seeing different time points from different cycles of vibration put together to demonstrate as it's one cycle of vibration. Okay. The next thing that we do with the stroboscopy or the video stroboscopy, it helps us understand the vibratory characteristics, the vibratory properties of the vocal folds. Tells us how the mucosa is of the vocal folds. Is it nice, moist, good vocal folds? Helps easy movement on the vocal folds, or does it have thick mucus on the vocal folds, making it hard for the vocal folds to move? If there is a lump or bump, how much is the lump or bump affecting the glottic closure? Meaning, is the closure like this, like an hourglass pattern with the lump sitting right there? Or is it a nice closure of the vocal folds even though there is a lump or bump on the vocal fold? If there is a paralysis of the vocal fold, how much the paralysis is affecting whether the vocal fold is coming to midline or is it just coming to paramedian position, so there is a lot of gap between the vocal folds? All of those helps us assess the laryngeal function. Why is this important? Obviously, laryngeal function is important because the vocal folds are ones that vibrate to produce the voice, right? Another thing that people have wanted to understand the vocal function is something called the electroglottography, or the EGG. Okay, all right. I don't have the other electrode, but I do have one electrode here. So basically, there's another electrode of this kind, right? It goes like this, right, at the level of your, on either side of the thyroid lamina, because that's where your vocal folds are. And what it measures is it passes an electric current from one vocal fold to the other. So when you think about the electric current passing between the vocal folds, if the vocal folds are open, there's going to be less electric current passing through the vocal folds. If the vocal folds are closed, there's going to be more electric current passing through the vocal folds. Now, you're not going to really feel that electric current. Okay, I'm not going to give you an electric shock, right? Electroglottograph, what it does is it actually traces a glottal waveform. It tells about the opening phase, the closing phase, how long it's in the closed phase, how long it's in the open phase. So it gives you a very gross estimate of whether there is anything going on with the vocal folds. So for example, if your vocal folds are too long in the open position or in the opening phase, that means probably there is more leak of air, which means there's probably a paralysis or a lesion which is preventing the closing of the vocal folds. So it gives us an estimate of the glottic closure or opening using an electroglottograph. Okay, so and a measure, what are some of the measures to understand laryngeal function? To visualize the vocal folds, you will use the video stroboscopy or rigid which is flexible or rigid. And the stroboscopy is the one that is going to give you a clear representation of the vocal folds. Endoscope is going to just give very gross information about the gross information about the vocal folds, not gross information of the vocal folds, not the fine motor control of the vocal folds. EGG is another measure of the laryngeal function, which gives us an idea of the glottal waveform. The waveform will include the opening phase, the open phase, the closing phase, the closed phase. It is an electric current passing between the two vocal folds with two electrodes placed on either side of your neck on the thyroid lamina. And it also gives us some information about what's going on with the vocal folds. Okay, so we talked about respiratory analysis, we talked about the laryngeal function. What you see right here is the flexible endoscope. This is that black catheter that actually goes through your nose. There's a camera that's attached to it, and you'll be able to visualize the vocal folds. Okay, so that's a flexible. I don't see a rigid here. All I have is a flexible picture. Okay, if you go on Google, YouTube, and look for vocal folds, assessment of the vocal folds, or video stroboscopy of the vocal folds, you should be able to get good videos about rigid and flexible video stroboscopy of the vocal folds, right? The final thing in terms of the peripheral analysis, so we talked about acoustic analysis, we talked about respiratory analysis, and the articulatory analysis. I did mention what is going to be the importance of doing the articulatory analysis is we want to see what is the placement of our articulators, where is the contact of these articulators, and how much contact do you need, how much pressure do you need, or what kind of contact is happening in order to produce a certain speech sound, right? So there are two ways to understand articulatory analysis. One is a palattography and the other one is an electropalattography. The difference between the two is that palattography is for isolated sounds, while electropalattography is actually for running speech. Now the difficulty, let me show you what a palattography looks like. This is an electropalattography that you see right there. Okay. So basically, they take an impression of your palate and they create electrodes that fit the size of your palate, and then you talk and these electrodes will pick up the placement of your articulators, how much pressure was used, what distance it traveled, things like that. It will give you an output to show you how each speech sound was produced. Okay. The disadvantage of using this palattography, electropalattography, most of the times it needs to be a custom fit device to fit your actual palate. It becomes very difficult. So if you have to use palattography as a biofeedback or a teaching tool for somebody to understand how to produce a speech sound, this requires a lot more investment because it requires an individual palattography or an electropalattography constructed for that individual. Most of the times it's not very much used in clinical practice, it's more so used in research purposes. For clinical practice, maybe it might be used in certain situations, but nowadays you have these beautiful videos online that you can actually look, which gives a sagittal view, mid-sagittal view of how your mouth looks like when you produce certain speech sounds. Okay, so for articulatory analysis, there are two kinds that you can measure: the tongue-palate contact and how your articulatory movements are during running speech. One is palatography, which is only for isolated sounds. Electropalatography is for running speech. So if I asked you, give me an articulatory analysis instrument that measures articulatory movements during running speech, your answer should be electropalatography and not palatography. Okay? So that sums up our peripheral systems that we talked, and what are some of the instruments that are available that can help us measure airflow, pressure, lung volume, articulatory analysis, laryngeal function, EGG, the endoscopy or the flexible endoscopy, rigid endoscopy, video stroboscopy. That's the one that's going to give us more information about the vibrational characteristics of the vocal folds. These are some things that I want you to really pay attention to. Okay. The other thing that I also want to do is a lot of people that talk about muscle activity. EMG, electromyography, helps us or provides us information about muscular forces. This is also a peripheral level. You are placing electrodes at the level of the muscle and you're recording the muscle action potential. So you have an action potential that fires from your brain, comes to the level of the muscle. There is a neuroreceptor, which is the acetylcholine. There is a synapse in the neuroreceptor, and there's the acetylcholine. So there should be, the action potential comes from the nerve, comes to the level, and then the contraction happens at the level of the muscle, and those contractions are called muscle action potentials. What does an EMG do? An EMG tells me how much of electrical activity is happening from a muscle contraction. What is the amplitude of the muscle contraction? What is the duration of the muscle contraction? Meaning, how long is the muscle contracting? How much is the muscle contracting? Okay, why is this important? Why do I need to know about muscle contraction? It is important to know if there is any weakness at the level of the muscle. Maybe it's the weakness of the muscle that's not helping it control as much. So the muscular forces are less. There is not as much amplitude of contraction. There is decreased duration of muscle contraction. A lot of people have done, especially in fatigue-related studies, if somebody says, they have a lot of fatigue, or they try to understand the mechanism of fatigue, they use EMG to tire the muscle and then see if there is a change in the duration and amplitude of muscle contraction. A lot of this has been done in physical therapy literature, and people have used information from the physical therapy literature and applied. I would say most of the studies has been done with the muscles of the mouth, at the level of the lip and the tongue is where they've done some of the EMG activities. A lot of people have used EMG activity at the level of the vocal folds, mainly the muscles, intrinsic muscles of the larynx, specifically to do with Botox treatment. If you've ever heard of spasmodic dysphonia, basically where your vocal folds spasm and you produce speech like this, with kind of like a strain to produce your voice, kind of like the breaking spasm that you hear. And people do EMG to understand that they're actually targeting the right muscle group to put the Botox in, so they can kind of paralyze that vocal fold, not paralyze that muscle, so there is not as much spasms in your muscles, so your vocal folds don't contract so much. Okay, so electromyography is a measure to understand the muscle contraction. In terms of muscle contraction, we want to know if the muscle, how long the muscle contracts and how much does the muscle contract, so the duration and amplitude. Most of the times it's been studied to understand fatigue, and in the laryngeal way, people use it to kind of give the Botox injections for spasmodic dysphonia. There are two kinds of electrodes that you could use: a surface electrode and a hooked wire electrode. Surface is actually the level outside. Hooked wire is actually a needle that goes in and kind of pokes. That's what they use for the laryngeal activity. Sounds weird, but I've had this done, had the EMG done. It's uncomfortable. It feels like a prick of a needle, but then once it's there, it doesn't bother you. A lot of people have used EMG to understand vocal fatigue. A lot of people have used EMG to understand lingual, tongue fatigue, lip fatigue. And those are some of the studies that I can think of in speech-related measures to use EMG. Nothing else comes to my mind right now, but those are some of the common things that comes to my mind right now in terms of speech, to understand speech production. People that have fatigue, myasthenia gravis, people have used muscle activity measures, hypertension, like hyper adduction of the vocal folds, people have tried to understand using surface EMG. Surface EMG, the problem with surface EMG, it covers a broader area, so we're not sure if it actually obtains the specific muscle group. Specifically, if you think about our speech muscles are so tiny, right? How do we know it's actually measuring that exact muscle that we want, because the muscles are so close together? So that's one of the disadvantages of using surface EMG. With a hooked wire EMG, yes, you might be in the muscle, but we move our muscles so much during speech. How do we know that it's actually in the same place and it hasn't dislodged from that position and moved away from that muscle? So each of these has its own advantages and disadvantages, but people have used this, people are using it, people have used this and will continue to use this because it provides information about muscle contraction. Okay, so if I ask you, give me a measure that helps us understand about the muscle contraction, then you have to say the EMG or the electromyography. There are two kinds of electrodes, the surface EMG and the hooked wire EMG. So we finished all the peripheral system. Now we're going to talk about some of the measures that helps us understand the nervous system. As you all know, the nervous system is our main controller. It helps us control all of the peripheral systems. So in order to understand the nervous system, there are certain measures. You probably obviously know some of those, the MRI, the functional MRI, fMRI. There is PET scans, CT scans. Event-related potentials are one thing that probably you haven't heard as much, which you will if you probably take speech science too, I think, maybe. But event-related potentials are also called the ERPs, which are electrodes placed on the brain to record electrical activity of the neurons. So it's like a cap which has electrodes. If you've had EEG done, or if you've seen anybody get an EEG done, it's very similar to that. It has a cap with all those electrodes in it, and you place that cap on top with a gel and it sticks to the certain area. So you're measuring the frontal, the temporal, the parietal area, so you're specifically getting information from the different lobes. Now the response is recorded in terms of two things. One is what kind of peaks do you obtain, whether it's a positive peak or a negative peak, right? You'll see it as a waveform and you'll see the peak being a positive peak or a negative peak in the waveform. The second one it measured is in terms of the latency. What is latency? Latency is defined as the delay between the stimulus onset and the response. So how long from when the stimulus is provided, the onset of the stimulus, to when you see a response from the brain, that is determined as latency. So if I talk about event-related potential, which is electrodes placed in the brain to record electrical activity of the neurons, there could be positive peak ERPs, positive peak event-related potentials. There are negative peak event-related potentials. There are short latency event-related potentials. There are long latency event-related potentials, meaning between the stimulus onset and the response is going to be very short. Quickly you'll get a response, versus a long latency. By the time you get the stimulus to the time that you get in terms of a response is going to be difficult. If anybody has been at the hospital and you've had a baby, the first thing that they do is to screen your hearing, right? So they'll come in and they'll place a couple of electrodes, one behind the ear, and they'll get in something called the ABR, auditory brainstem response, which is a short latency potential where it's like it's a click, 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 and it's the brain's ability to perceive that click, okay? Now, for event-related potential, most of the times the stimulus is an auditory stimulus, meaning you're hearing something. And some of the studies they've done are visual event-related potentials, but I will not go into that for now. All I want you to understand is most of the times the stimulus that you present to understand an event-related potential is the auditory stimulus. The responses can be two different kinds. One is a passive response and one is an active response. So, if I were to talk about a passive response, meaning ABR, which is one of the things that the kids do, obviously the infants are not going to be able to give a response, right? Whether they heard or they didn't hear. So passive response is the brain is automatically responding without any response expected from the client or from the participant or from the patient. An active response is something that the participant has to provide a response to. So for example, you will hear click, 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 click. Alright, or it will go pa 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 pa. And whenever you hear that odd stimuli, which is the b or the click that I gave you an example, you have to hit a button, meaning you heard the difference. Okay. So let's talk about this again. Most of the time your stimulus is going to be an auditory stimulus. There are two kinds of response, a passive response and an active response. Passive response where the participant does not have to provide a response. So if it goes click, 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 you don't have to do anything. The brain is sensing it and it'll say that your brain heard it or it didn't. An active response, or your brain perceive the difference or no. Your active response is you have to click when you hear the difference. So if you go b b b b b b b b b, then you have to hit for the b. Or if you go click, 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 and then you have to hit a button. The potentials can be short latency potentials or long latency potentials. As I said, latency is the delay between the stimulus onset to when you get the response. Short latency is the delay is really short. So ABR is an example of that auditory brainstem response. Long latency is for a cognitive process assessment. So it takes longer to perceive that. So it is a cognitive process assessment. Okay. So now ABR is auditory brainstem response. MMN is mismatch negativity. Okay. P300 is positive peak 300. N300 is negative peak at 200. Okay. And that's the time. 300 and 200 is in terms of time. 300 milliseconds and 200 milliseconds. Okay. So event-related potentials, or ERPs, help us get electrical activity from the neurons. Most of the time the stimulus is going to be an auditory stimulus. The response can be you need to have a passive response or an active response from the client. You need to have the potentials can be a long latency potential or a short latency potential, and those are some of the examples. So if I asked you, give me an example of a passive response short latency potential, your answer will be ABR, short latency. Okay, but if I give me an example of a passive response and a long latency potential, MMN will be an answer. So you see the point? You need to know what is a passive response, what are examples of passive response, what are examples of active, what is an example of short latency, what is an example of long latency. Again, let me reiterate. ABR is auditory brainstem response. MMN is mismatch negativity. P300 is positive peak 300. N200 is negative peak 200. Okay. Some of the why you're like, okay, why do I care about this? Why should I know about all these latencies? Why should I know about event-related potentials? What's the need? A lot of people have used event-related potentials to understand a lot of things. In the auditory field, they've used for categorical perception, meaning like the p, 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 b, p, 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 b. That is a categorical perception, where the voicing switches, right? All it's to do with the voicing sound. So it goes from the p to the b, and the duration has to be, the VOT has to be shorter. It has to be 25 milliseconds and less to perceive it as a voiced sound. Whereas a voiceless sound, it's longer. The VOT is longer in duration, right? So that is a categorical perception task. And central auditory processing disorders, into children that have central auditory processing disorder, where they can maybe hear it, but they can't process it at the higher level. The people have used event-related potentials to understand that. How do we process language? People have used event-related potentials. People have also used to understand stuttering in event-related potentials. They perceive that maybe individuals with stuttering have different event-related potentials than individuals that are that do not stutter. So these event-related potentials help us understand the norms, helps us understand what happens in normal individuals if we had to work with the patient population. All right. So event-related potentials are potentials that help us obtain electrical activity from the brain. So a set of electrodes are placed in the brain. The stimulus is usually an auditory stimulus. It can have positive peak or negative peak. The latency can be short or long latency. The response can be a passive or an active response. And I want you to know examples of each of those. Okay. So how about on the discussion board, you give me an example of one short latency potential, give me an example of one long latency potential, give me an example of one active response, and give me an example of one passive response, ERP. So let's say that again. I want you to, in the discussion board, give me an example of one short latency potential, one long latency potential, one active response potential, and one passive response potential. Okay, it'll help you remember. I know everybody will give me the same answers, and I kind of see that it'll be just, but if you keep looking at everybody's discussion board, if you keep looking at that information, you'll remember that better, and that'll be tested on your exam. All right. Next is called the PET, the positive emission tomography. It's an invasive procedure. I'm not going to go into real details about the PET, the MRI, and the fMRI because these are not things that we typically do, but I do want you to know that these are used in research purposes. Okay, so PET is a positive emission tomography. It's an invasive procedure. You inject a radioactive material, and they want to see how much accumulation of the radioactive material is there in the brain and what is the blood flow to that region. Okay, so I'm not, as I said, I'm not going to go into details, but I do want you to know that positive emission tomography has been used in the speech world, typically to understand actually stuttering. As I said, people think there are differences in the areas of the brain in individuals who stutter and compared to individuals that do not stutter. They have found certain areas that are larger in individuals who stutter compared to individuals that do not stutter. So PET is one way for us to understand the brain. MRI and fMRI, I'm just not going to, as I said, I'm not going to go into too much details about that, but MRI and fMRI helps us also understand the functional activity and just the structures of the brain. It measures the distinctions in soft tissues in our brain, and it helps us understand, and that's an instrument that looks like that. It is a scary procedure. If you're claustrophobic, you really cannot go in and do that procedure at all. Okay. So, what are some of the measures that we use to understand the brain? If I say list me 3 measures that help us understand the nervous system, you can give me event-related potentials, MRI, PET scans, fMRI. Those are some ways that helps us understand the nervous system for speech purposes. Okay. So that sums up our clinical instrumentation